is Rebecca, and today I'll be discussing the diagnosis and treatment of depression at the end of life. In this video, I'll start by talking about the prevalence and impacts of depression at the end of life. I'll then provide an overview for differentiating between depression and the normal grieving process. Finally, I'll outline treatment options for depression at the end of life. Depression at the end of life is very common and often overlooked. Gardos et al. Estimated a prevalence of depression of 39% in patients in the very last week of life, and Kozlov et al. Conducted a retrospective interview of caregivers and found a 43% prevalence of moderate to severe depressive symptoms. Younger patient age was associated with an increased risk of depression. A study by Water et al. Found that 3/4 of patients with cancer and likely depression did not receive effective psychiatric treatment. Several studies have also looked at the impact of depression at the end of life, including a study by Vasilopoulos et al., conducted among hemodialysis patients with end-stage renal disease. This study found that depressive symptoms were unsurprisingly correlated with decreased overall quality of life. Another study found that depressive symptoms corresponded to increased caregiver burden, including caregiver feelings of guilt as well as their own symptoms of anxiety and depression. Thus, depression is clearly a common part of the dying process, and untreated depression at the end of life hinders the goal of reducing suffering among patients and families at the end of life. It is often difficult to identify depression. Symptoms used to diagnose depression in other circumstances, such as fatigue, weight loss, sleep changes, and low energy, are common at the end of life as a result of the patient's underlying disease, even in the absence of depression. In addition, many patients with terminal diagnoses experience preparatory grief, a cognitive, emotional, and spiritual response to the understanding that one has a life-limiting diagnosis and that death is approaching. The experience of preparatory guilt can occur anywhere along the end-of-life spectrum, but often revolves around the point at which the patient's disease becomes obviously life-limiting. Patients who are experiencing preparatory grief will often have a waxing and waning mood, but with an intensity that gradually decreases over time or predictably responds to new stressors or changes in the patient's condition. In contrast, patients with depression often have persistent dysphoria and low mood. Other symptoms that increase the likelihood of depression include a sense of worthlessness or loss of self-esteem, inability to enjoy or look forward to events, hopelessness, or persistent social isolation or withdrawal. For patients who are experiencing preparatory grief, social and spiritual support services can help patients go through the grieving processes. Patients with severe grief may be assisted by specific grief counseling. For patients with depression at the end of life, Lorenz et al. Conducted a meta-analysis and found strong evidence for antidepressant therapy, including tricyclics and SSRIs, as successful for control of depression when continued for more than 6 weeks. Specific antidepressant treatment can be determined based on the side effect profile and patient needs. Patients with depression also benefit from psychotherapy and emotional support. Due to the long onset of action for antidepressants, Pertoil et al. From the American Academy of Family Physicians suggested using stimulants when a faster treatment is needed. However, studies for the use of stimulants for depression at the end of life have been inconclusive. Sullivan et al. Conducted a study of patients at the end of life whose depression was not responding to SSRI treatment and found no benefit from additional methylphenidate treatment. Starr et al. Conducted a meta-analysis on the subject and found that the data for the use of methylphenidate to be inconclusive, though many studies trended towards a positive effect but lacked statistical significance. Caregivers of patients at the end of life also experience high rates of anxiety and depression. Ramirez et al. Reported that the prevalence of anxiety and depression among caregivers of cancer patients was as high as 46%, with depression specifically as high as 39%. Meta-analysis conducted by Lorenz et al. Found weak to moderate evidence supporting interventions to reduce this burden. Examples of interventions included specific skills training, emotional assistance, and in-home support. Effect sizes were small, but comprehensive and individually targeted interventions were more likely to be effective. There's also evidence that early palliative care involvement in interventions improved caregiver satisfaction. In summary, both grief and depression are common in patients at the end of life. Depression is often overlooked and can impact both patient and caregiver quality of life. Treatment for depression at the end of life includes psychotherapy, antidepressants, and possibly stimulants. Personalized interventions for caregivers can reduce caregiver burden and help reduce the high rate of depression in caregivers as well.